For people who don't know me, I'm Jane Weller. I am a commissioning and contract manager at Liverpool City Council, but have an integrated role across the CCG as a lead for carers for the city, and I lead for carers of all ages, so young carers through to our older carers. So that's me. So next slide, please. I don't know who's in control of the, oh, there you go. So in terms of vaccination process in Liverpool, we took the decision to implement a localised process rather than, directing any unknown carers through to the National Booking Service. So I sat on the stakeholder group as part of the development of the SOP for vaccination of unpaid carers, and one of the roles that we undertook in Liverpool was to support the Department of Health and Social Care to understand the data sets. And so as we were looking at those data sets, sort of feeding that information back into the stakeholder group so that they understood where our known carers sat, what those figures looked like, and the type of population that we would be working with. So obviously we took our flagged carers from CCGs, our local authority data across adult and children's services in terms of carers who had a carers assessment, but also those that were supported in their caring role through the care and support plan of their cared for person. The provider market, so our main commissioned services, our adult and young carers service, and then DWP, obviously, we were hoping that we might be able to get that data locally through a memorandum of understanding, but they chose to obviously do that nationally, and that was fine. So obviously we then went through that process to identify who our known carers are. I appreciate this is tiny writing on this slide, but that was the process that we went through. We used the COPI arrangements to enable the data sharing, and because we already have a contract in place with our carers services to input directly into our client records system, they are data inputters and we are the data controller. All of the data was owned, so there was already those data sharing protocols in place, which made it a lot easier, really. So if we go to the next slide, please. Thank you. Thanks. So how that kind of sort of played out was, according to the last census, which is dated, we appreciated that, but it is the one fixed, sort of population that we know and understand. We have 50,000 carers in Liverpool. 23 unpaid carers records were pulled from the source system. So following the cleansing, and we did batch tracing locally rather than depend on it happening nationally. So that gave us a cohort of 21,500. From that cohort, we knew that we definitely had 15,500, the majority of which were recorded on their GP record, which was really, really positive. It was a really pleasant surprise, actually, that, across the piece, the majority had been supported and encouraged to register with their GP. So that was a real positive for us. And then there was a further 2,000 that were only recorded on the LA system, and obviously how that broke down then by age band. Then there's a cohort of sort of our known unknowns, if you like. So there were 6,000 where we needed to start doing some data cleansing around that. And that was because there was in the batch tracing, it was either, you know, their name was Max something and it might have been recorded slightly differently or spelt slightly differently, or, you know, they were known through our system as Tracy, but really on their GP record, they're known as Elizabeth because that's just how it is. So we started doing that data cleansing as well. But what we realised was we had quite a significant proportion of unknown carers that we needed to obviously encourage to come forward for vaccination. So what was very clear from the message from the clinical commissioning group as well as ourselves was we wanted this to be a legacy piece of work, that any unknown carers could come forward locally, have a local offer of support ongoing, but would then be recorded on their GP record as a carer. So therefore, moving forward, they would have those offers of flu vaccination, any booster vaccination within the priority cohort, and also health checks, as well as the support from the local carers service as well. So that was what we really wanted to try and establish. So next slide, please. So the process that we put into place was that unknown carers were invited to come forward to identify themselves to the carers centre. So that application for a vaccine, they will be screened against the framework, the eligibility framework within the SOP. What was really useful about having the carer service do it, because they have the knowledge, the expertise and the experience to support carers to actually not underplay their caring role as well, which, you know, often we find that through assessments, etc. So, you know, that was a really positive process. They could do that via telephone, e-form or email, and the Carers Centre expanded their operating hours to ensure that there was evenings and weekend cover, and they could take those calls and support carers. Carers development workers would then get back in contact with the carer and take them through a very simple screening process. And it was basically, you know, are they the sole main carer? Or if somebody did share equally that process, they would then be invited to come forward, whether they cared for somebody within the identified cohorts, and also whether that they were providing personal care on a regular basis. So, you know, we obviously defined what all of that meant. So the carers development workers also had sort of a script almost and prompts to follow and to encourage carers to identify what it was. If unpaid carers weren't eligible for whatever reason, the carers development would also have a conversation with them about how they could maintain a safe environment, you know, continue to social distance, how they could care safely. They also process our PPE applications for carers, so they would offer PPE and also information and advice about infection prevention control and so on, and also ensure that they had ongoing support with their caring role if that was the case. If they were eligible for vaccine, the carers development workers had the ability to book them straight onto their vaccine appointment through our localised systems. So they could either book into one of the hospital hubs, which surprisingly were the most popular for carers, or they could book it via the GP vaccination centres, or if a carer was unable to access the community for any reason, they could request a home visit for a vaccine for the whole household. They too would obviously be given additional advice about caring safely and the risks of COVID, and also given that offer of ongoing support around their caring role. There was in total 2,270 contacts as of last week. Some were just contacts to ask questions, but of those, 1,655 were screened. So we're really pleased that we were able to support an additional 1,500 or just over 1,500 carers to access their vaccine in the priority group. So it's given us a lot of learning. We probably would have hoped for more in one sense, but we do know that the national booking system did go live, and we did promote that as an option because some carers may not have wanted to come forward through this process. But we're really pleased in the sense that more carers did come forward and have been identified for ongoing support. So next slide, please. So that's just some of the feedback that we've received from carers. And, as you can see, it's meant more than just kind of a vaccine, really. Many of them said it's given them their life back. They've got a future of hope now. And the fact that everything was done in one call, that was a really important thing for carers. That was a lot of the feedback that we got, that they couldn't believe it, that they made the call and that they hung up with a date and a time for their vaccine. They knew that they could get there. If they had have had difficulties accessing the vaccine centres, we were able to provide support with that. And locally, Uber had been offering free taxi rides for people who couldn't afford to get to their vaccination centres as well. So we were linking in with partner agencies who were offering that support as well. Next slide, please. So the next steps from this, so obviously legacy was a really important part of this. And in terms of the carers that have come forward, their GP records are being updated, and their carer flag is being added to their records. There is a proposal that is being taken to our chief exec's management team to take a proof of concept for a citywide place-based intelligence solution. And because of the work that was undertaken with carers at pulling together a number of different data sources, it was decided that there was already some positive work going forward. So that model has been in place since January. So the vaccination programme for unpaid carers has provided that legacy and that learning, and we just wanted to build on the momentum with the GPs and the PCNs, because one thing that's been really clear is that carers' voices have been really central to that whole system approach. Another piece of work is around behavioural insight work that we want to undertake with our public health colleagues. And that is to look at what are the motivations for carers to self-identify as an unpaid carer. The vaccination process offered a tangible something to motivate carers to come forward, that they would be receiving something in return for their identification as an unpaid carer. But actually, without that, what are those motivations? So we're hoping to engage an organisation to undertake that work with us at a time that's right, obviously, due to COVID. But then that will inform a more personalised local offer. The aim being that we identify carers very early in their caring journey and build resilience into that caring relationship with a targeted offer of information, advice and support. And then we also want to explore the deeper linkages with social prescribing and an electronic carer health check that can assess the risk factors of becoming a carer. And I think colleagues might be on the line from, I'm trying to think where it was, somewhere in the northeast, that we're trying to arrange a meeting with, because I know that you've done something similar within your area. So it would be good to take that learning. So that's us for now. I'm sure there's lots of questions. I've been conscious of the binging, but I couldn't keep up with that. So
not to worry. Thanks, Jane. So there's a few sort of questions and comments actually. So Sue Younger-Ross has commented about, she wasn't completely clear about how you got the carer service able to make vaccination bookings. Could you give us a bit more clarity on that?
Yes, so we'd set up a local system for health and social care staff. So organisations and agencies providing domiciliary care and our care home sector, etc., could book their staff onto their vaccination appointments via a local system. I'm sorry if I don't have all the terminology, to be fair. So we just made that available to the carers centre so that they could book onto the main hospital hubs. So it was our Royal and Aintree sites, our Broad Green site, and then book for the GP vaccination centres, the more localised ones. It was established, we would email, it was a team member within the clinical commissioning group with the details, so that information went over securely, and then a text message would be sent to the carer to say that they'd been booked onto it. So that's how it operated. I don't know if that fully answers the question, but I can get the technical stuff if need be.
No, that sounds brilliant, Jane. Thank you. And there's a couple of comments around the behavioural insights work. Just people really seeing the value of that. And I wonder if that might be a really good topic for a future one of these ICS calls. Actually, I'm seeing some thumbs up from Ray. Lovely. We've done quite a lot of work with behavioural insights at a national level as well. Yes, more thumbs up appearing on screen. Good. So Jane, hopefully once you're sort of shaping that work, if we could invite you back with the people you're linking in with, that would be fantastic. Yes, certainly in terms of things like the discharge work and the carers leaflet, which I know was not necessarily perfect, but behavioural insights from government side of things were very much involved with that. And we've done quite a lot of work with behavioural insights team as well. So I think it might just be a really good way of thinking about particularly what you were saying about that, encouraging people to identify early as a carer, because that does seem to be the terminal stumbling block, doesn't it?
It does. And obviously with the research and the evidence base, whereby if we do identify carers early, their health outcomes are far better than if we wait for them to reach crisis. It's kind of our public health team undertake a lot of behavioural insight work, and it kind of came from obviously conversations with them, but the campaign that they ran around alcohol reduction was actually what they found through that BI work was that it wasn't about, if you talked about reducing alcohol, it wouldn't have an impact. What did have an impact was talking about calories. So actually how many calories you consumed. So their campaign was quite different, really. So so we thought, well, obviously there must be something that's going to motivate carers. So we'll see how it pans out. But yeah, we're just kind of working it into all of the kind of all the reset and recovery work now. So hopefully it'll happen this year. Or that's the aim, that it'll be in the behavioural insight work plan for this year.